All right, we've got 11:03, so we'll go ahead and get started. My name is Ann Garvey. I'm with the Iowa Department of Public Health. I'm the Deputy State Epi. Joining me on today's webinar is our Medical Director and State Epidemiologist, Dr. Caitlin Padati. We want to just take a few minutes and go over all of the guidance that we've been sharing recently to make sure that everyone has access to it and understands how to get to that guidance on our website. So you should be seeing my screen on your webinar. I'm just going to click through how we would get to the long-term care guidance and our healthcare guidance, and then I want to talk through a few things. So if we go to our long-term care guidance, there's a couple of things I want to point out. And the first thing is the protocol for long-term care facilities who have 2 or greater residents or staff with respiratory illness. So we're asking that facilities report to us. You'll see our 800 number on the screen whenever they have 2 or more staff or residents ill with respiratory issues. And what we'll do at that point is walk through sample collection with the facilities and help them coordinate specimen pickup so that we can get COVID testing done quickly at the state hygienic lab. We'll also be talking to these facilities about measures that they need to take in the interim while we're waiting for results to come back. And so we just want to point you to this protocol for facilities that have 2 or greater illnesses, again, in staff or residents. Now, for our long-term care facilities that are experiencing outbreaks, we also have a checklist listed that really talks through all of the things that we're asking these facilities to do. So I want to take a few minutes and talk through this checklist. And the first thing we want to make sure all facilities are doing is that they're screening their staff at the beginning and end of each one of their shifts. And if staff become ill with any type of respiratory symptom or a fever, they need to be sent home immediately. If there are any residents that have respiratory symptoms, we want those individuals to be isolated in single rooms immediately. We're also asking that our long-term care facilities do daily temp checks and assessments to determine whether any residents are developing respiratory illnesses. And again, we want all of our staff to be using face masks and eye protection at a minimum at all times for all resident care. Now again, these are facilities that are currently experiencing outbreaks. If they have gowns and gloves available, ideally they should use that for all resident care, but if they don't have enough gowns, then the priority would obviously be that they use those for ill individuals. Everybody should be restricting guidance to or visitors to the facility already, except for the end of life situations, and CMS has guidance on that. We do want long-term care facilities to start coordinating with their local partners to include local public health and their local hospitals to make sure that they have a plan in place to communicate when they have residents that have respiratory symptoms and fever, so that any of the transport services, so all the EMS understand that they have a COVID-19 suspect patient that's being transferred so they can use proper PPE, and also that the hospital understands that that's suspected in the patient so that the patient can be triaged appropriately at that hospital. One thing we really want to emphasize to our long-term care partners is that people infected with COVID-19 do start to worsen in symptoms and illness on day 7 or day 8. So that's a really important thing to keep in mind. We want to make sure that as residents are having respiratory illness and fever and COVID-19 infection, that we're really monitoring them closely on day 7 and day 8 for symptoms. We also want to make sure that if there is an outbreak in a long-term care facility, that they have test kits readily available on site so that they can test additional residents that become symptomatic. And we want to make sure that you have a plan in place to communicate with your staff, your residents, their families, and your community partners. And finally, one piece of information that we ask for when we're working with facilities that are having outbreaks is we want to know if they have staff that work at other healthcare facilities, because we want to give these other facilities a heads up to make sure that they're increasing their surveillance among their residents and staff should this individual become ill. So that's something that we don't normally ask for, but we want to make sure that those alternate healthcare facilities understand that there are things going on at this current facility and they need to enhance surveillance. And that staff that works at multiple facilities, if they're going to continue to do that, they need to be using a face mask and eye protection at all facilities that they were working at, not just the one that's currently having the long-term care outbreak. So again, I just wanted to walk through that checklist with everyone. There's a couple of additional resources on our website that we want to point you to. There are 2 draft letters for long-term care to consider when you're communicating about either a staff member who's tested positive for COVID-19 or when there's illnesses in your residents. So these are posted on our website. You don't have to use these. We just want to make sure that we have a resource out there for facilities to grab quickly if they do have cases in their staff or in their residents. There's a couple additional documents that I want to share with you. They're in the healthcare tab. The first one is our guidance for face mask and respirator extended use and reuse. And we're all very aware that we're currently having a shortage of PPE, so it's important that all healthcare facilities really understand that this guidance exists and follows it if needed when we get into these situations where there's not additional face masks or respirators available. So you'll note that there's discussion about extended use, about reuse, there's N95 mask cleaning guidance, and in addition, there's discussion of use of homemade masks. I also want to share the guidance that we have in place for the use of homemade masks. And basically what this guidance says is that if there are no commercially available masks, homemade cloth masks can be used, but they need to be used in conjunction with a full face shield. So that's something to keep in mind as your facilities maybe are going to be transitioning to the homemade face masks throughout this response. It's important to make sure that those staff members are also using face shields. We do also have guidance posted for the public about face mask donations. So this is posted under our guidance for the general public. So again, I just wanted to take a few minutes to walk you through where those resources are on our website, as I think they're going to be critical for all of you moving forward. We certainly appreciate all that you're doing to address COVID-19. We know that it's a very difficult time right now, and that there's a shortage of PPE supply, and that is causing additional frustrations. But again, we appreciate everything that you all are doing to respond to this global pandemic. We do have our partners from the Department of Inspections and Appeals on the line. I'm going to attempt to open Patrice Fagan's line here so she can share some additional information from Department of Inspections and Appeals. So please stand by.
Can you hear me? Hello? I'm called in as number 42. Okay, everyone, it seems like they can hear me, so I'll go ahead. I wanted to talk about our focused infection control surveys that CMS has directed us to do in the CMS QSO 2020 All memo we received on the March 23rd. So we have started those surveys. We started last week, and the ones we did last week were completely remote because they had COVID in the facility, and we were unable to attain PPE. So we will be doing these surveys for the duration until we're told not to, or until we've completed all 439 facilities. For facilities that are not requiring PPE, we will be entering the facility, have one person off-site, one person on-site that will come in and gather some information, do observations and a few interviews, and then leave the facility and finish the work remotely. We are asking to have access, remote access to medical records, if that's a possibility for your facility. If your facility does not have the system required to give remote access, then we have a couple of other things that we can do. We can request that you scan the pieces of the medical record that we need and scan it to the team leader in email, or if you don't have that ability, we can have you print those pieces and fax them to the office, and we'll get them to the surveyor. We want to be as least intrusive as possible, so we will be in and out quickly. The surveys won't last days like they do. They might last one day, and if there's a large facility, we might be back in the next day for a little bit. So we're depending on whether or not there is remote access available and whether there's PPE available for us. If we go into a facility with COVID and we don't have PPE and the facility won't provide it, then we will do that survey remotely. The CMS has directed us to do these as we would any other complaint investigation, so we wouldn't be requesting a large amount of patient or resident files. It would be a concentrated amount, depending on the size of your facility, that we would normally pull for any complaint that we're in there to do. Is there any questions about that right now?
If you have questions, please enter those into the Q&A box, and we'll work through those at the end of the formal remarks. Patrice, did you have anything else you wanted to share, or?
I did. Yeah, I just, yeah.
Into questions.
I just wanted to also say that on the QSEP site, that we use for training, anyone can go in there and access the QSEP training for the focused infection control surveys, and also all facilities should have received the QSO 2020, and it has the tool attached to it that we use during our survey. But if you go to the QSEP, you can also see the protocols, the entrance conference, and those pieces that go with the survey. So any questions from there? I don't have anything else at this time.
All right, that sounds great. I think we'll transition to questions. Again, we really appreciate everybody joining today's webinar. We wanted to just give you some updates on additional guidance and resources that we have available, and then clearly we have plenty of time for you all to ask questions of us. So we've had a couple of questions come in. Again, please enter your questions into the Q&A box. The first question is, many nursing homes are having trouble getting testing kits, and hospitals are not consistently sharing. So we appreciate that feedback. And if you're going to be doing testing and sending it to the state hygienic lab, you can request kits from the state hygienic lab. They do have a limit on 6 kits being requested at a time, but if we're having an outbreak situation, then obviously we can help get you additional kits. But just to have kits on hand, which I think is a good idea, I'm showing you on my screen how you can order kits. The State Hygienics website is just shl.uiowa.edu. When you get to that main page, the way I get there is I just click on order a test. And then the first link in the middle of the page is order clinical kits. So all you need to do is fill out your request and the number of kits, and you will likely be required to just order 6 at a time. So I would just order 6 into that bar. The one thing I want to make sure we're clear on, the kit that we want for COVID-19 is a virus isolation and detection kit. So that's the one that you would select. Okay, we're going to move on to the next question. If a patient in a long-term care develops signs and symptoms, would they need a prior approval from IDPH for testing? No, not at all. So all positive test results are required to be reported by law to the department, and we'll get those results from laboratories and facilities that do that testing. And we are asking that if you have 2 or more staff or residents who have symptoms, that you give us a call, but there's no approval process for submitting the tests. And one thing I do want to show you, I'm going to go back to our website. Again, clicking on the novel corona banner at the top, and I'm going to go to healthcare. Sorry, I clicked the wrong one, healthcare. And there is a COVID-19 testing framework. I'm going to pull that up. And you'll see the bottom 2 bullets on the testing guidance. And again, this guidance is only in place for the state hygienic lab. Healthcare providers can send tests to any other lab that's performing the testing when they see fit. But for the state hygienic lab, we're trying to preserve our resources, our testing resources, to use it at our highest risk situation. So I'll point you to these last 2 bullets. And the first one is persons with a fever or respiratory illness who live in congregate settings. So that would include a long-term care facility. It's listed there specifically. Anyone who has a fever or respiratory illness can be tested at the state hygienic lab. And then the 4th bullet talks about healthcare workers. And this would include staff working in a long-term care. So staff in the long-term care and residents can be tested at the state hygienic lab, and there is no prior approval necessary. So we're getting some questions about PPE and what the proper process is to request additional PPE if your facility is out and is not able to obtain more. So you would need to communicate with your state public health, or excuse me, your local public health department, who's going to be coordinating that with your county emergency manager, and they can make those requests of us. And for as long as we have PPE, we're filling those requests. So that would be the process. I would say I do want everyone to make sure that they're seeing that guidance that I did just talk through about donated face masks. And so that is something that I think we're going to be needing to utilize in Iowa. And it's important that everybody knows that you need a full face shield when you're using those cloth donated face masks. We have a question about really reuse or extended use of PPE. And I think that most of the questions that you will have are really going to be answered in this document from CDC. As far as gowns and gloves, they would need to be changed between each resident. But for the face mask and respirator use, we can use that guidance that I'm showing on my screen right now. We have heard that it's hard to get the face shields to use in conjunction with homemade masks. that's definitely something we're working on. We're hearing more and more there may be people who can make those types of products, and we're trying to obtain those at the state level. So please go through the same request process for face shields that I just described for other PPE, going through your local health department and your county emergency manager. Would wearing a homemade face mask on top of an N95 extend the life of the N95? I think rather than taking that step, I would point you towards the reuse and extended use guidance. And there is guidance on cleaning N95 masks. Again, this is based on a study at Stanford. It's cited in the guidance. That would be probably a more appropriate way to extend the life of N95. We have a comment for our DIA partners. These surveys are going to increase stress for long-term care exponentially. We're already under so much stress. So thank you for that comment, Patrice. I don't know if there's anything you want to mention there.
Sure. We are aware of the circumstances, and CMS has given us this directive to do these surveys. So we're looking at ways to be as least intrusive as we can be, and that's why we're doing most of the work remotely. When you look at the packet and the information that's required, if you go to the QSEP, you can see what we will be requiring at entrance. You can put together packets for your facilities to have ready for when we do come. We're looking to guidance from IDPH and from CMS on which counties we're going to in what order. So that's where we get that guidance from also. That was another question. So that's my suggestion, is that you would go and get those documents and get prepared, and that will keep you ahead of the game, and we will try to be out of there as quickly as possible. Thank you.
Okay, there's a couple more questions for DIA. Will the surveyors be bringing their own PPE, Patrice?
If there's PPE required in the facility and we have not received any, we will do the survey remotely. If the facility has extra PPE that they want to provide to one surveyor, then we would go ahead and come in, and that's if you have a COVID positive case. Otherwise, we will be doing remote surveys until we obtain PPE for our staff. Okay, question about, is DIA surveying all facilities? This came in a couple times. Yes, the plan is to do all 439 facilities unless CMS tells us differently.
Okay. Sorry, we've got some repeat questions along that line, so I'm just clearing those out. Next question, have we noticed a trend or concern, and what can we learn from that? I think that we all know that long-term care facilities are a high-risk setting because we have groups of vulnerable populations living in close quarters with each other. We also have healthcare providers who are at high risk because of the nature of them coming in contact with residents. And so both of these scenarios really are concerning from the standpoint of making sure that we can keep COVID out of our long-term care facilities. And so we are certainly concerned about long-term care facilities. That's why we want to be intentional about having this back and forth conversation with you all, and are trying to create guidance that is helpful to you and helps you kind of use all the resources that we have to the greatest extent possible. Certainly from the standpoint of what we're seeing here in Iowa, we are hearing from a lot of our long-term care facilities that they're having some illnesses, and we are trying to work closely with you all to make sure that you can take measures to try and mitigate the spread within facilities, and certainly we appreciate this as a terrible, difficult position that you're all in, and just appreciate everything that you're doing to address these. Some repeat questions. We had a comment about wanting facilities to continue to work together to support each other. If you have additional context for that comment, just please enter that or reach out to us after this webinar. We certainly want to be supporting you all any way we can, because again, we greatly appreciate everything you're dealing with. What do we consider respiratory issues when evaluating residents or staff? We would recommend that you consider this pretty loosely. So sore throat, any cough, something that's a change above their baseline. We would recommend that you consider respiratory symptoms. Again, if you have any staff who have any type of respiratory issue, we'd recommend that you send them home immediately. Hopefully you're doing that screening before they come in, and so they don't enter the facility. And certainly if you have any staff, or excuse me, residents that are exhibiting respiratory illness, we want you to isolate those individuals right away and make sure that you're taking those measures that we talked about earlier in this webinar. Question, clarifying the use of PPE in facilities. You would like us to wear full PPE only if in an outbreak with residents. So at this time, our recommendation is focused, excuse me, our recommendation is focused on facilities that are having outbreaks. However, as we move through this response, recommendations may change, but right now we're really focused on those facilities that are having respiratory illness in staff or residents. There's a good question here. It's kind of a complex question, so I'm going to try and distill it down. It's really asking, what is our definition for a long-term care outbreak? And we're using the CDC's recommended definition, which is at least 3 residents with COVID-19 infection. And so that's what we're officially using. However, we are also being a little bit loose, and when we're recommending that facilities try to adopt some of the measures on the outbreak checklist. So if we have 2 residents, for example, we would recommend that you start thinking about implementing as many of those recommendations on that checklist as possible. There's a part of that question also really was looking at the spread over time. And so the bottom line is we're really wanting to make sure that if there's any indication that there could be transmission within a facility, that we're taking those measures. And so we'll take time as far as when the cases were diagnosed into account when we're making those recommendations with you. But we're really, what we're trying to get at is if there's indication that there could be transmission within the facility, we want you to take those measures. How long does it take on average to get results after employees have been tested? That's a great question. And part of that is going to depend upon which lab is doing the testing. So the State Hygienic Laboratory has about a 1-day turnaround once they receive the specimens. But then you have to remember there's time in transit for those specimens to get to the lab. There's a lot of healthcare providers that are sending specimens for testing at other outside reference laboratories, and the turnaround time at those laboratories is variable, and we cannot speak to that. So the short answer is it kind of depends on where you're sending those specimens, and so that would be something to ask the healthcare provider who you're working with to send those specimens, asking them what lab they're being sent to and what the turnaround time is at that lab. So a good clarifying comment. The question is, if there are 2 or more staff or residents, do we notify local public health and IDPH? So to keep it, you can notify, technically you can notify either or. We just wanted to be able to give you one phone number. So if you call us, we're going to engage your local public health department. A good question. As a long-term care facility, should we be testing our staff, or do we send them somewhere to be tested? So I do think that probably a best practice would be to just have your staff go to their regular healthcare provider and have them be evaluated and tested there, rather than trying to keep your staff in your facility and do the testing. Because the bottom line is, if you've got sick workers, we want them out of the facility as soon as possible. So we don't really want you to keep them there to do the swab. The easiest thing is probably just to send them to their healthcare provider. Yeah, and again, you do meet the SHL criteria, so there shouldn't be an issue of healthcare workers being tested. And by criteria, that was the last document that I showed you. I'll pull it up really quickly again, this testing framework document. Again, that's applicable to the state hygienic lab, and the 4th bullet includes healthcare workers and essential service personnel, and that includes long-term care facility staff. How do we handle a return to work situation where staff members only had a fever and no other symptoms? So in these situations, we do have a document on our website that talks about essential service personnel, which would include long-term care facility workers. And it talks about the isolation guidance. You should be seeing it on the screen right now. So people should be off of work for at least 7 days from when their symptoms started. So if they only had a fever, then from the day that they started spiking a fever, 7 days from then, they should be off work. Now, if they had a fever for more than 4 days, we want them to be fever-free without the use of fever-reducing medications for at least 3 days in addition. So, for example, if somebody had a fever for 6 days, we want them to stay home for at least 9 days, because we want them to be fever-free for at least 3 days before they come back to work. Again, this document's posted on our website, and it also addresses isolation recommendations for people who have been exposed to COVID-19. So if you have a worker who says they have a sick child at home, but they're still symptom-free, we want them to isolate themselves for 14 days when they're not working. They can come to work, but when they're at work, they need to be using full personal protective equipment, especially the procedure mask, to make sure that should they become ill down the road, that they aren't spreading it to residents and their coworkers. So again, this document's posted on our website. A question, when you say department, are you talking about public health or DIA in the requirement to report cases by law? I'm talking about Iowa Department of Public Health. So there is a reporting order in place that requires by law that positive COVID-19 test results be reported and negatives be reported to the department. We've got some repeat questions here. CDC mentions 2 swabs 24 hours apart for return to work. We have really transitioned in Iowa to the guidance that I just provided. So rather than bog down our healthcare systems taking repeated samples, which every time we're taking a repeat sample, that's another set of PPE for that healthcare provider that's conducting the swab. and also using testing resources. So we are really basing our return to work guidance on the time frame. So again, at least 7 days, but then also have to be fever free for 72 hours. So for 3 days.
And I think I would add, if you look at the CDC guidance, they offer either a clinical or a testing pathway. The clinical pathway is what we've just described. And the reason they offer those options is because early evaluations in detecting viral load indicated that at 7 days, the viral load has gone down to a point where they wouldn't consider people infectious at that point. So that's what that's based on.
Yeah, one positive and one staff member, one resident and one staff member in a long-term care developing a fever with respiratory symptoms. Would that be reportable? Yes, we are asking that you reach out to our department when you have situations where 2 or more residents or staff have respiratory illness or fever. We have set aside a couple rooms for isolation if a resident starts having respiratory symptoms and they have a roommate. Do we move the symptomatic resident into the isolation room? I saw a different guide to not move that resident throughout the facility and to isolate that resident and their current roommate in the room since the roommate has already been exposed. So we would recommend that either the roommate or the sick individual be moved into the isolation room. We would not recommend keeping an ill person and a well person in the same room. For staff illness reporting, at what point do we want to get reports? With fever or mild respiratory symptoms. So again, we would want you to be doing that screening prior to staff entry, and anybody who has respiratory symptoms or a fever, that's an or, they should be sent home immediately. And if you're having 2 or more residents or staff who are ill, then we'd ask that you reach out to the department. If we have test kits, can we test our staff and send it in? So the one thing I want to be really clear on is we're only recommending testing staff that have symptoms. We don't want to test asymptomatic staff. So if you do have symptomatic staff and your preference is to test them there at the facility and your medical director will order that testing, then that's fine to conduct it at the facility. We're just suggesting that it might be appropriate to send them to their own healthcare provider because then they can be medically assessed as well. Would a facility, okay, I think this is a question for you, Patrice. Would a facility be cited for failure to follow their P&P for infection control based on the sole fact that they have a CSE in their building? Would fines be issued on deficient infection control practices found by the surveyor?
Okay, I think they mean if they have a case in their building. We wouldn't cite you just because you had a case in the building. No, there could potentially be deficiencies, but they would relate to if your policies and procedures didn't cover the essential infection control policies and cover, the proper PPE, and all of the other requirements as set forth with this guidance from the 2020 document, the QSO 2020 document, which was sent ahead. There could potentially be. It doesn't say there would be, but there may be some guidance to that. The purpose of this survey is not to be so punitive as it is to make sure that you're prepared for the outbreak. So that's why we ask, or CMS asks, that you do the assessments, and then we come in and we also look at the things to see that you're prepared for a pandemic. Sometimes there's things that are blatantly wrong, and that might get a deficiency, but no, not on the sole fact that you have a case.
Another question for you, Patrice. Are the focus DIA infection control surveys in addition to the scheduled annual survey, or is this a combination with the annual survey?
No, in the QSO 2020 directed us for the 3-week period beginning March 20th that the only surveys that we would be conducting would be the focused infection control survey, any complaint that is in immediate jeopardy, and initial survey. So we wouldn't be doing any other surveys on top of or in conjunction with the infection control survey unless we had an immediate jeopardy with it. Then we may do that while we're in the facility.
Another couple questions for you, Patrice. If the facility is not a CMS facility but is a private pay only, will they also be surveyed?
We wouldn't have, we are mirroring what CMS is telling us to do, and I guess I would have to defer that question to higher up management if we would mirror the infection control into private pay facilities. CMS is giving the direction for all of their facilities that are under contract.
Where is the QSEP you're mentioning, or where do we find the DIA documents?
The QSEP, on our web page, there should be the documents that you can find there, but the QSEP is, I think you can probably Google it. I can't access my computer right now with the screen up, but I can send that information to you if you want, and then you can put it on your website as well, or I can put it on, have them put it on our website, how to access that training program.
Okay, that sounds great. We can definitely link to it. Some additional just comments about being concerned about having the surveyors visit the long-term care facilities and possible concern about their ability to spread among facilities. Another question is, what is the time span that's expected for all surveys?
I guess for all surveys for all facilities, or time span on each site for all facilities. I guess I need a little definition there.
I think the latter. I think the latter.
Okay. We anticipate the surveys will be completed in one day. With a large facility, we may have to go back or finish up the next day. Most of the work, though, keep in mind, will be done off-site, and the exit conference will be done off-site as well, remotely via telephone.
Okay, a question on, I think they're asking about the scheduling of the surveys. Where would they find information on when the surveyors are coming?
We are not, these are still unannounced surveys, so we don't make that public information. We are taking direction from CMS and Iowa Department of Public Health on which counties we should go to first, and we will go down that list and survey as we're directed.
A good question. So based on the governor's closing of salons, are long-term cares able to have hairdressers provide service to residents? So no, we don't think it would be appropriate to bring outside salon personnel in to do patients' hair at this time. Again, anybody who's coming into the facility has a potential to be bringing in COVID-19, and so we think at this point during this pandemic, we would not recommend taking that risk. A question about how many people have tested positive for COVID-19 in Iowa. I'm looking to our final number from this morning. We're pulling that, and we'll share that with you here in a minute. How long will it take the surveyors to get through all Iowa facilities? A month or 2 months, question mark?
We haven't determined that yet. We're working on scheduling as we go.
Patrice, that one's for you.
Yes, can you hear me?
Do you have a sense of how long it'll take the surveyors to get through all of the Iowa facilities?
Not at this time. We're working on scheduling now. Can you hear me? Okay.
So the updated numbers of persons in Iowa infected with COVID-19, so these are the people that tested positive, is 424. If a resident has been treated with an antibiotic, does that affect the COVID-19 test? There's no indication that there would be any interruption or any interference with that testing, regardless of antibiotic use. If residents are spaced out 6 feet in all directions, is this still considered communal dining? Dr. Podati is coming over to answer that one.
Yeah, I know that, again, we're asking for a lot of really tough and sort of strict measures here. I think the preference would really be particularly in a facility that has ill residents, that residents take their meals in their rooms. And I understand that you're saying you've got people spaced out, but again, I think when we think about this big picture, we know that these are our most vulnerable people. Anything we can do to limit contact or spread within a facility is going to be wise for this vulnerable population right now.
There's a question. I cannot locate the return to work information on the website. So I'm showing that on my screen right now. It's isolation guidance for essential service personnel. So the top half of the document talks about people who are well that have been exposed, and the bottom half talks about sick people and when they can return to normal activities. And the way you get to it off our website, so I'm showing our main page. Eventually, here's our main page. You click on the banner. You go down to essential service personnel. Sorry, I clicked on the wrong one there. And it's the isolation guidance, so it's the first document posted there. Where can I find the QSO 2020 information? Patrice, that's the document you said that we should be linking to from our website, correct?
Yes. The QSO, it should be on our website and available. And you can also, if you can't get to that, you can just Google CMS QSO -20-20-all, and it should pull it right up for you.
Okay, great. Some more questions about salon employees. So what if the salon employee is not an outside employee? They are salaried by our center and do not work anywhere else. Can they do hair in the residence room if they're screened prior to doing so?
Yeah, I still think that, what we're trying to do is limit any entry of any person into a facility at this point, unless it's really for, an essential or important part of care. And I don't mean to minimize that service. I know that that's important for a lot of reasons. But again, my recommendation is going to be that we limit the entry of as many people as possible, because we just know that these are our most vulnerable people.
Question about, is there an archived version of this webinar that will be available? We will post that on the long-term care link on our website, so it'll be posted here like our previous webinars have been. So for example, these are our previous webinars. Is it considered a visitor if the resident meets them outside to visit and stays 6 feet away? So again, really what we're trying to cut down on is the potential for outside exposure to your residents. So we would recommend that you take every effort possible to make sure that we're not having your residents exposed to outside individuals who may be infected with COVID. Will the surveyors be tested for COVID-19 prior to entry into our buildings? And also, if they have been in a building which later is identified to have COVID-19 in it, are they still going to be visiting additional buildings?
Yeah, we wouldn't recommend any testing of asymptomatic people at this point, but I appreciate and understand, you know, your concerns here.
Okay. A question about someone who hasn't received follow-up on their PPE requests. Again, we would recommend that you just reach back out to your local health department and your county EMA for an update. Is it reportable if we have to take a known COVID-19 patient from a hospital? So this is someone who was previously diagnosed with COVID-19 and then they're looking for to be placed into your center. So in those situations, we would already be aware of that individual because we would have received that report from the hospital. And so there's nothing that you would need to report to us. What about staff coming to work that do not provide hands-on care? Should they still be coming? So I'm not sure exactly what categories of staff this would refer to, but certainly you should be restricting staff to those staff members that you need to provide care for your residents, and everybody should be screened when they enter the facility. So if there's additional context there, please.
Yeah, I'm not sure if you mean like people who cook or some of your environmental services, you know, all of those people, yeah, are definitely considered important parts of the functioning of your facility, even though they don't provide direct patient care. So the recommendation would be those people, you know, can and should still come, but they just need to be screened.
Under the isolation guidance, does this include other staff like maintenance, laundry, housekeeping, dietary? It does. They would all be considered essential service because they're needed to keep your facility functioning. Did I hear correctly that any staff member with a temperature should stay off work for a minimum of 7 days? That's right. Anybody who's got a fever should stay out for at least 7 days. If they have that fever longer than 4 days, they may need to stay out an additional period of time because we need them to be fever-free for at least 3 days before they come back. Are activities staff considered essential services staff? And so it would really depend upon what functions they're performing. For the most part, we're asking that you limit interactions amongst your residents. So if if activities staff are now doing additional activities or additional work, like helping in the kitchen or things like that, then they would be considered essential service staff. The fever cutoff is 100.4, correct? Yeah, that is the cutoff that we're using. However, we would say that if your staff members are seeing an increasing fever, we would want you to be pretty conservative there and send them home. So if they have a 99.9 and they're normally running, you know, 97, we would be concerned about that, and we want you to be pretty broad in your implementation of sending home sick people.
Yeah, I think, also including subjective reports of fever, anybody who's telling you they're not feeling well, we want to explore that and take that seriously. And then clinically, we know in our older folks that sometimes they don't get fevers, right? Sometimes they actually go low. And so just keeping in mind that, changes in temperature, either high or low, particularly in residents, are things you want to pay attention to.
Do I understand that even if they just have a cough, they should stay out for 7 days? That's right. So any symptom, we're recommending they stay out for 7 days. We know that this is hard, but again, we want to just be really conservative and make sure that we're excluding people, because we know that there's a broad spectrum of illness with COVID-19 infection. People can be more mildly ill, and we don't want to miss anybody that could spread it to your residents. Does COVID-19 live on your shoes for days?
Yeah, some of the early investigations into how long this virus can live on surfaces, it suggests that it depends on the surface, whether or not there's biologic material, and that sort of thing. Early estimates suggest it ranges from a couple of hours to as many as 3 days. I think keeping that in mind is helpful, but I think that what's more helpful is if you think about the ways that somebody could potentially get sick from this, it really has to do with, having germs on our hands that we then put in our mouth, eyes, and nose, or being in close contact with somebody who's sick, who's coughing or sneezing on us, right? And so if we wash our hands routinely and frequently before we touch our mouth, face, and nose, before we eat, and if we stay 6 feet away from other people, those are really the interventions that will prevent the virus from making you sick. There's a question about, helping to meet needs of patients who may have more of a risk of choking when they eat and need a little bit more assistance and need to be monitored. Yeah, no, we certainly understand that. And so, if somebody needs to be monitored and you're able to maintain those 6-foot distances, and for safety reasons, they need to be watched closer, that would be a reasonable thing to do. Just try and, maintain that 6-foot distance, use the PPE, and practice that kind of social distancing. There's a question about shoe covers as part of PPE. It's not currently a recommended piece of the protection here. What we're really thinking about is what we know about how this virus moves, right? Which again is droplets, coughing, sneezing from one person to the other. And so trying to focus on limiting those kinds of things. There's a question about guidance for offering video chats and assisting residents with phone calls for their families, particularly because we've limited activities and visitors. And that's a good point. And I do think that can be considered an important thing that we want, to do, an important service we want to offer people. Just making sure that we're doing that in a way where we're screening, the people who are entering the building and using any appropriate PPE.
I know we're coming up on just over an hour, so we've got quite a few questions still in the queue. Many are repeats, but there's at least 4 more that we want to take. We appreciate your time. If you need to jump off, that's certainly fine, but I want to get through a couple of these. So we have some questions related to what if the employee has a chronic cough or has known allergies. And we know this isn't perfect, but anything that's different from their baseline, we would want you to make sure you're excluding for.
And I think, that's also why it's important to keep in mind that we recommend that people use their own healthcare providers when they need to, whether that's telehealth or calling to talk with them about their own symptoms. And if they've noticed any changes in their baseline, that'll be important. And it's also why we make the recommendations on using, PPE for patient care in high-risk settings.
Question about our recommendations for N95 respirator use. We do still recommend N95 respirators be used when aerosolizing procedures are occurring. So nebulizer treatments, for example, that is still our recommendation. So some questions about reuse of the N95. We direct you to take a look at that document that we showed earlier in the presentation, and that talks about extended use or reuse. A couple of comments about, we have staff that want to wear face masks now with all patients, even with no confirmed illness in the building.
Yeah, so we know that that's something that, other facilities, have considered sort of independently. And I think thinking about, whether that's something that you would have the supply and ability to do is something to consider. And I think, as Dr. Garvey mentioned, right now we're focusing a lot of our recommendations around PPE use in settings where we have sick people, but those recommendations may continue to evolve. And again, I think taking a step back and looking at the big picture, we know that the long-term cares have a couple of things that make you higher risk. You've got your older people with underlying conditions, they're living in close quarters, and it's a healthcare setting. And so I think we just want to recognize that we know that this is a high-risk population, and we know we've asked you to do a lot, and you continue to do a lot, and we're so incredibly grateful, and we're going to keep working with you on figuring out the best ways to keep both residents and staff healthy. There's a question about certification for CNAs. We can see if we can follow up on, any sort of changes or adjustments or things we can do to help support increasing the certification process for CNAs.
I think for the most part, we've hit all of the questions. Again, as Dr. Padati said, we greatly appreciate all of your ongoing efforts and everything you're doing to respond to this pandemic. Please reach out if we can be of assistance, and have a good rest of your afternoon. Thank you.